In the clinical simulation lab, your training focuses on diagnosing a single patient, often down to a single tooth. For the service learning module, the scale of diagnosis expands to encompass the entire population residing in a given service area. To diagnose requirements at that population level, we use a systematic public health tool known as a community oral health needs assessment. The necessity of this tool comes down to a basic math problem. Clinical resources, government funding, and provider time are strictly finite. Consider the demographic landscape of Malaysia. You have highly dense urban environments where millions of people live in close proximity, contrasted with starkly different realities in rural regions where geographic isolation creates entirely different disease patterns and structural barriers to care. Without a formal needs assessment, allocating scarce resources across these diverse populations is a guessing game. To distribute care equitably, we need an evidence-based strategy. This diagram illustrates the three distinct variables we must map to accurately diagnose a population's baseline health status. The first variable is scale. This measures the epidemiological reality of the community, tracking the exact prevalence and severity of specific diseases. The second variable is gaps. This evaluates the physical and systemic barriers in the existing healthcare infrastructure. Gaps include logistical issues like a lack of reliable public transportation to clinics, or a regional shortage of state-funded providers that accept low-income patients. The third variable is preferences. This captures the cultural values, internal beliefs, and behavioral habits of the community itself. Preferences can be the most complex data point to map because what a community wants often contradicts what the clinical data suggests they need. Reconciling that contradiction requires a specific analytical framework. Identifying the exact scale of a disease offers little value if public health planners fail to map the structural gaps and human preferences that actively prevent treatment. To resolve the tension between clinical standards and community desires, public health professionals rely on Bradshaw's taxonomy. This framework categorizes health requirements into distinct types. The first is normative needs, which are the objective requirements formally defined by health professionals. A normative need is established when an expert evaluates a population against established clinical benchmarks, like the World Health Organization's diagnostic criteria. The second category is felt needs. This is the community's internal perception of what they actually require, driven by their own personal and cultural values. When a community translates those internal feelings into observable actions, like actively seeking specific care, that becomes an expressed need. These categories frequently collide in practice. For instance, a Ministry of Health might identify a normative need for a school dental sealant program to prevent decay. However, the parents in that community might be dealing with children already suffering from severe cavities. Their immediate felt need is urgent pain relief, not preventative coatings. If planners push forward with the sealant program while ignoring the community's demand for pain management, the normative intervention will likely suffer from low utilization. Clinical outreach succeeds only when the normative clinical data is integrated with the community's expressed voice. Once scale, gaps, and preferences are mapped, that raw data must be fed into a structured four-step cycle. Phase 1 is identify. Here, we synthesize the raw data to pinpoint the most critical health issues. Phase 2 is plan. Planners collaborate directly with NGOs and community leaders to design interventions and allocate scarce resources. Phase 3 is implement. This is the execution of the policy, whether deploying clinical care teams or launching health promotion campaigns. Phase 4 is evaluate. In this step, we measure actual health gains achieved in the community against the baseline data collected at the start. A common trap is viewing these 4 steps as a linear checklist with a definitive endpoint. In reality, the process is strictly iterative. The data gathered during the evaluation phase instantly becomes the new baseline data for the next identification phase, keeping the cycle spinning. A community oral health needs assessment is never finished. It functions as a continuous operating system, designed to adapt as the population's health profile evolves over time. The primary reason this assessment cycle must remain continuous is that the baseline epidemiological reality of the population is actively shifting. Historically, public health dentistry centered heavily on acute, episodic care, deploying teams to manage untreated cavities through mass extractions. Modern populations require a different approach. The disease burden has shifted toward complex, chronic conditions, that demand sustained management rather than one-off surgical fixes. This diagram illustrates the bidirectional relationship between periodontal disease and systemic conditions like diabetes, which is a prime example of this modern shift. Untreated periodontal disease induces systemic inflammation that exacerbates diabetic complications, while uncontrolled blood sugar simultaneously accelerates the destruction of gum tissue. This chronic disease feedback loop forces a structural change during the plan phase of the assessment cycle. Modern needs assessments must pivot away from isolated dental extraction camps and toward engineering long-term integrated partnerships with general medical teams. By identifying exactly where scarce resources can produce the maximum health benefit, the needs assessment framework allows practitioners to apply principles of equity to their clinical work. As you transition out of the university simulation clinics and into your service learning placements, this framework becomes your primary diagnostic instrument. Avoid the trap of assuming you know what a community requires based purely on your own clinical biases. Before you pick up a scaler or a drill, you must identify the true scale of the local disease burden and the hidden structural gaps preventing access. Actively listen for the community's felt needs and reconcile those desires with your normative guidelines to ensure your interventions actually take root. Equitable resource allocation begins with accurate identification. To execute your role as a public health professional, the cycle of care must start with diagnosing the community as a whole.